Hello, everyone. I am Dr. V. Mohan. It's a great pleasure for me to participate in this very prestigious conference and to talk to you on the subject of precision medicine. Is it a reality? At the outset, I would like to thank Professor Inas Shalthout, who kindly invited me for this meeting, and also Professor Shehnaz, who introduced me to Professor Inas Shalthout. I'd also like to thank Professor Rafat Rashwan, Professor Amir Abdul Wahab, and my very good friend, Professor Mohammed Hasneen. So congratulations on the 16th International Conference of the Arabic Association for Study of Diabetes and Metabolism being held virtually at Egypt. And I'm so glad that I could participate. Of course, I would have loved to come to Egypt myself. I've come 2 or 3 times now, three times to Egypt, and I just love your country. So next time, I would love to come in person. I have no conflict of interest to declare. All the studies in this presentation are either supported by government funding within India, the Indian Council of Medical Research or the Department of Biotechnology, Department of Science and Technology, or from international funding from either the UK or the US. Now, let me start at the very beginning. This is a term which is used quite commonly now, precision medicine. And I'm actually part of the American Diabetes Association's Precision Medicine Initiative, or PMI. And we are actually now coming up with a second consensus report for which we are all working very hard. And by next year, we should have a series of publications on the second consensus report. But the first consensus report was published a couple of months ago, simultaneously in Diabetes Care and Diabetologia, where the term precision medicine has now been expanded to include precision diagnosis, precision therapeutics, precision prevention, precision treatment, precision prognostics, and precision monitoring. So you can see how much the term has expanded. And all of these, of course, in the connotation of diabetes. So I would request all of you all to read this paper published in Diabetes Care, which sets out this scene. But I'll make it very simple for you. We are obviously not there yet with all of these. Many of these are just concepts. This is my own little definition that when you talk about precision medicine, it's a very narrow concept. It's based on science. So you have all the scientific inputs you have, whether it's genes or environment or response to therapy. And if you put it all together, you can say for this particular patient, this particular medicine seems to be the best. And that's precision medicine. But personalized medicine takes it one step further. What if after you say that this is the best medicine, the person with diabetes is not willing to take it for some reason? Suppose you say insulin is the best for this particular patient, in a type 2 patient, and he says, no, I will not take insulin. What do? Then you have to take the patient's social context, preferences, discuss with the patient, and individualize the treatment for that particular patient. That is what is called as personalized medicine. So personalized medicine is also precision medicine, but it's tailored to the patient's need, and that's why it's called personalized. Okay. Now, coming to diabetes, personalized diabetes, of course, you can have it in any form of diabetes. Type 1 diabetes is always possible, but it's too broad, and I'm not going to go into all aspects of it given the limitations of time. Let's talk about some personalization with respect to type 2 diabetes. That's where the clustering of diabetes has come in very recently. And then, of course, I'm going to spend more time on the monogenic forms of diabetes, and particularly 2, maturity onset diabetes of the young, or MODY, and neonatal diabetes, or onset of diabetes below 6 months of age. This is where I believe that personalized medicine has actually come to the diabetic clinic today, and we are actually practicing, and I'll show you some examples of that. So let's start with type 2 diabetes and the clustering of diabetes. Now, this really had its birth when Leaf Group and colleagues from Scandinavia published this paper in the Lancet Diabetes in 2016-17, showing that there are novel subgroups of adult onset diabetes. So when we take type 2 diabetes, we think it's all one disease. And that's how guidelines are written. Try metformin. That doesn't work, you try something else. That doesn't work, you try something else. That's like taking a lottery ticket. and saying this the ticket doesn't mean the other ticket will win. So that is a shotgun approach. But if you try to classify the patients as LEAF group and colleagues did, and they actually came down to 5 different subtypes of adult onset diabetes. The first one they called as severe autoimmune diabetes, or SAID for short. The next one is severe insulin deficient diabetes, or SID. Now, the basic difference between these two is that in the SAID variety, GAD antibodies were positive by definition. Whereas in the SID variety, they are also thin, young, insulin deficient, but their GAD antibodies were negative by definition. And I would actually argue that this variety, the SAID variety that we are talking about first, is not really type 2 diabetes. It's a form fruit of type 2 diabetes, or you can call it type 1 diabetes, type 1 1.5 diabetes, or a variant of type 1 diabetes. We can also call it as LADA, or latent autoimmune diabetes of adults. But really, this is not a true type 2 diabetes. But this one, the SID one, is a true type 2 diabetes. Insulin deficiency is the biggest factor there. Now, the next one is the insulin resistant type, the exact opposite of the SID. You have a lot of insulin is not working, insulin resistance is the main problem. You have obesity here you are lean, so there are two contrasting types. Then they defined a third variety called as mild obesity related diabetes, where you have obesity, but it's a healthy obesity. You don't have insulin resistance, no metabolic syndrome. That is the third variety. And the last one is based on age. If you get type 2 diabetes after 60, 70, and so on, they called it as mild age-related diabetes, or MARD. So they had these 4 varieties plus the 5th one, which is SAID. Now, we wanted to see whether these 5 varieties or 4 varieties can be replicated in our South Asian population, particularly in India. And when we did that, the first thing we did was that we said, let us see whether the same applies to our population. We removed the SAID variety because we said that autoimmune diabetes is a different type of diabetes. That we are not dealing with this. They're thin, they need insulin, C-peptide is low, they're behaving like type 1. So we removed that. And we said, whoever is GAD antibody positive, we're not bringing into that. But we'll use the other characteristics, the clinical characteristics that they had described, and see whether it fits in with our population. And the reason we wanted to do that is because the diabetes in India and in South Asia, Pakistan, Bangladesh, and so on, are very different from what we see in the Western countries. First of all, you get diabetes in lower age group. Then the BMI is much lower. So you can get lean diabetes as well. You don't need obesity. Insulin resistance, of course, is there, but insulin deficiency seems to be the bigger factor. We seem to be losing beta cell function very quickly in our type of patients. And then there's this characteristic dyslipidemia, with HDL being very low, triglycerides being high, and a number of other factors which I won't go into. So we took up the study as part of the INSPIRED study. INSPIRED stands for India-Scotland Partnership for Precision Medicine in Diabetes. This is a collaboration with the University of Dundee and our Madras Diabetes Research Foundation in Chennai. It's funded by the National Institute of Health Research, NIHR, in the UK. This is published in BMJ Open Diabetes about 2 months ago. When we tried to classify it into the same 4 groups using the same parameters that LEAF group and colleagues used, we found that the first and the last, namely the SID variety, the severe insulin deficient variety, and the MARD variety, the mild age-related variety, were the same as what they found in Scandinavia. However, the other 2 types that we got were completely different from what they had reported. We found an insulin-resistant obese variety, IROD variety, and a third variety, which is very interesting, called as the combined insulin resistance and deficiency variety, or the SIRD variety. Now, here you have both insulin resistance and deficiency, like the SID and IROD combined together become SIRD. They had not reported such a group in their classification. What we also found was that the lowest HDL and the highest triglycerides was found in this particular group. Now, why are we bothered about all these clusters? Why are we doing this precision diabetes? Because the susceptibility to complications also changes. They also showed, and we are also showing, that the SID variety, the severe insulin deficient variety, is the one which is more prone to retinopathy. That is what they showed. But in their other groups, they were not so much prone to retinopathy. We found, however, that apart from the SID variety, the third variety, which I told you, the combined variety, they were more prone to retinopathy as well. So we have found two groups which are more prone to retinopathy. Now they found that the obese variety, which is insulin resistant, is the one more prone to kidney disease. And we were able to confirm that. If you look at the insulin resistant variety, if you look at the CKD, the chronic kidney disease comes out better that compared to the MARD group. The SID variety did not have more of nephropathy, whereas insulin resistant variety was more prone to nephropathy. But again, this combined deficiency group, the insulin resistant and deficient variety, had the highest risk for diabetic nephropathy. So this is a point of interest, that the third variety, the combined insulin deficiency and the resistant variety, is not only more prone to kidney disease, as the Scandinavian group said, they are also more prone to retinopathy. So that was very important. Even more interest was how much time did they take to get under control. So as one would expect, this MARD variety, the age-related one, is so mild that you can get your diabetes controlled. This is the percentage of people who reach HbA1c less than 7% within a particular time, 10, 20, 30, 40, 50%. You can see the green line is the MARD variety. They easily reach the control. Not surprisingly, as Leaf group showed, the SID variety took the longest time to reach the target of 7%. But again, the third variety, the combined insulin deficiency and the resistant group, because they have insulin deficiency, they behave like the SID variety. So these two groups, the combined insulin deficiency and resistant and the SID variety, were the most difficult to treat. Now, you would have found many patients who come to you where you're able to easily bring their sugars under control. Their A1C comes down very easily. Whereas others, you struggle. It takes a long time for their sugars to come down, even if they're following diet and exercise. And now we are able to say for the first time why this is so. There are subgroups within type 2. Some of them are easy to treat. Some of them are not easy to treat. And that, I think, is what precision diabetes or personalized diabetes is all about. Think of which patient you are treating and treat them accordingly, giving them personalized treatment, and they will respond much better. I'll rest my case there as far as type 2 diabetes can go on. But in the interest of time, I want to show you something more interesting, which is absolutely fascinating, actually, and that is the monogenic forms of diabetes. This type of diabetes, called as MODY, or maturity onset diabetes of the young, was described by Tattersall and France in the year 1975. And I remember, as a final year student, when I read this paper published in Diabetes, I was all excited because I was already working for many years as a medical student doing research on diabetes. When I read this, I said, hey, this seems to be quite common in our population. So what they described in 1975 was that this is the early onset type of diabetes. They behave like type 2 diabetes, but they don't have obesity and they don't have acanthosis nigricans. And they are not type 1 because there's no ketosis, there's no autoimmunity. They can be controlled without insulin. They have good C-peptide or fairly good C-peptide. They have insulin secretory defect, but not like type 1. And so this is a separate, and the most interesting part is that there is a single gene defect. One gene is mutated, and that causes MODY. Now, that's not the case in type 2 diabetes or type 1 diabetes, where multiple genes are involved, and they are only associations. You have like 100 genes which are responsible or associated with type 2 diabetes. But here, a single gene is enough, and that's why they're called as monogenic forms of diabetes. In fact, later the field exploded, and today we have almost 14 different types of MODY, okay, of which the MODY 1, 2, 3, and 5 are more common, and the rest are less common. And the beauty is that if you have MODY 1 or MODY 3, the HNF1 alpha is called MODY 3, and the HNF4 alpha is called MODY 1. These patients respond very well to sulfonylurea because the defect is in the pancreas. It is not sensing the glucose. If you give a sulfonylurea agent, it works very well. Even better than insulin, even better than metformin, better than anything else, these agents will work. So we'll have to keep this in mind when you're treating young patients, because MODY patients respond better to sulfonylureas. Now you may ask me, why should we bother about all this as a clinician? Give one thing, doesn't work, then you give something else. As I said, that is like treating, like asking an astrologer how to treat diabetes or taking a lottery ticket. You're not following science. You must try to subclassify your patient to find out which type of diabetes you have. And when I show you a case study, this will become more obvious to you. Here is a 16-year-old girl. She's thin. She presented with severe diabetes. HbA1c is 10.4. And when she went to a local physician, he said, this is type 1 diabetes. 16 years old, thin, you got HbA1c 10.4. What more do you want? This is type 1 diabetes. So he told her, you start 3 to 4 times insulin per day and lifelong you take it. They were very upset and they wanted a second opinion. All people with type 1 diabetes get upset when you tell them that. So many type 1s will come to me for a second opinion. And of course, many cases turn out to be type 1 diabetes. So I tell them, yeah, this is right. You have to take insulin. This is an insulin dependent type. You will die if you don't take insulin. You have to continue. But in this particular girl, something very interesting came. The first thing we do is to draw a family history, okay, pedigree chart. Now, this is the girl, the proband here. What we found was her mother had diabetes. Her aunts, many of them had diabetes. Father's side, there was no diabetes. So she seems to have inherited this from the mother. And look at the number of generations which have got diabetes. Mother, so she had it, mother had it, second generation. Her mother's parents had it, that's the third generation. And if you go above, a great-grandfather also had diabetes. So there are now 4 generations of diabetes in this girl's family. This is what Tatishal and Fayance describe. And that's why we take a pedigree chart for everyone. People with type 1 diabetes very rarely will have a family history like this. So this alerted us. Are we dealing with something else and not type 1 diabetes? And then, of course, we have an algorithm which we follow to clinically classify the patient. The first thing we do is C-peptide assay. That will tell you whether insulin secretion is there or not. In type 1 diabetes, 0 insulin. Okay, straight away you know that there is no insulin secretion. It's type 1 diabetes. When we did it for this girl, she did have a significant insulin reserve. So we said, hey, that's strange. Again, it doesn't look like type 1. Now, there are specific antibodies with which you can diagnose type 1. GAR antibodies, zinc transporter antibodies. We have do all this routinely at our center. We did them. They came negative. Okay. So I said, okay, here is this girl who's young, who's got 3 generations of diabetes or 4 generations of diabetes in family. Her insulin reserve is good and the antibodies are negative. Are we actually treating type 1 or is there something else in this girl? So we decided to order for Modi genetic testing. And lo and behold, we found that she had a gene for MODY3. This is a HNF1 alpha, and it is a novel mutation described for the first time in this particular family, arginine to histidine mutation. And the mutation was found in her and in her mother, and everybody in her mother's side shown in red here who had diabetes had the same mutation. And guess what? By this time, her younger sister, because it took a long time for us to get this genetic testing. Those days, it would take us a year or so to get the genetic testing result. Today, we can get in 2 weeks' time, 3 weeks' time. Those days, it used to take a year. So by the time her genetic test came, her sister had also developed the same disease, and she also had the same mutation. So it is very clear that this girl had MODY3, which she inherited from her mother. And so what should we do now? She is MODY3. MODY3 responds to sulfonylurea. So we stopped insulin. We started her on sulfonylurea, glibenclamide, which is the most studied drug in this case. She showed an excellent response. HbA1c came down to 6.8. And today, after about 10, 15 years, both she and her sister are both responding to sulfonylureas, that is to glibenclamide. And this is a classic example of how the Modi genetic testing helped to avoid unnecessary lifelong insulin therapy. Imagine if we didn't do all this, she'd have been treated as a type 1 diabetic, and throughout she'd have been taking her insulin 3 times, 4 times a day. And this is the value, and this is the beauty of precision diabetes. You can see how it is life-changing. You may say, is this the one case that you have, or you have more cases? I have more than 300, 400 such cases of Modi where we have clearly been able to say which type of Modi it is. And remember, not all Modis respond to sulfonylurea. There are about 5 or 6 types of Modi which respond to sulfonylurea. Some of those Modis are not really true Modis and they need insulin. Okay, so only by genetic testing we're able to do that. Now, if you thought this is fascinating, listen to the last part of my talk where I'm going to talk about neonatal diabetes. I don't know how many of you have seen cases of neonatal diabetes. These are, hold your breath, patients diagnosed below 6 months of age. 6 months, newborn baby, okay? Only 1 week old, 2 weeks old, 3 months old, and they have diabetes. Now what happens? Immediately when they're diagnosed with diabetes, they start on insulin. In fact, Professor Andrew Hattersley used to say that below 6 months of age, you don't even get type 1 diabetes. It is all neonatal diabetes. Today, he has disproved it. And he says, no, no, you can get type 1 diabetes also below 6 months of age. But a significant number of them don't have type 1 diabetes. They probably have neonatal diabetes. Now, neonatal diabetes of two types. One is called permanent neonatal diabetes, which will continue. Once you're diagnosed, you will have it throughout life. There's another interesting variety called transient neonatal diabetes, or TNDM. Now, in these cases, it will be onset will be third month, fourth month of age, but before the first birthday of that child, the diabetes disappears. It may come back after 15, 20 years, but for the time being, it's gone. Okay, that particular gene which produces it produces TNDM. Whereas what we have seen, this has been reported from Europe and US and so on. The most of the cases that we see with neonatal diabetes are actually permanent variety. We are only two with the transient neonatal variety. We have done hundreds with the permanent neonatal diabetes. Okay, this is one of our first reports, which we published in the year 2012 in Clinical Genetics, where we had 33 cases of neonatal diabetes at that time. Now we have a much larger series. What is interesting in this is the clinical characteristics. After we diagnose, now remember there are two major genes where you can have the mutation. One is called the KCNJ11 mutation. The second mutation is called the ABCC8 or the sulfonylurea receptor mutation. And majority of the neonatal diabetes or NDMs have these two mutations. And if you have these two mutations, you will respond to sulfonylureas. Okay, so that's why you should do the screening. Now, look at the response. This is the A1C levels of these children before they were started on sulfonylurea, when they were on insulin, 14, 16, 10, 11, and so on. This is HbA1c. We stopped after doing the genetic testing, we stopped the insulin completely, change them over to glibenclamide, and you can see the response of after the sulfonylurea is given. 14% A1C became 7, 6 became 5.9, 16 became 6, 10.8 became 7.4. So you can see a beautiful response to sulfonylurea. Blood sugars also, fasting blood sugars came down dramatically. Now this is almost life-changing. Imagine a newborn baby coming in, told that it's type 1 diabetic. We're saying, no, stop it. Give this tablet to this child. And then the child's sugar is completely under control. It's nothing short of a miracle. It's one of the most satisfying things to treat in diabetes, according to me. And that's why it makes headlines like this. Genetic test helps to treat diabetic infant. This child came from Calcutta, all the way from another big city. And we were able to, treat this child. And what this headline says, doctor says ignorance about the disease is widespread. Because people don't even think about it. Once they, diagnose, tell, oh, this is type 1. And then they start, treating the child. And the child is given insulin for the rest of their life. So I would like to conclude, ladies and gentlemen, on that note by saying that precision medicine is slowly becoming a reality in the field of diabetes. Identification of clusters of type 2 diabetes may change the way we treat diabetes in the future. For example, if you suspect a young, lean, thin man, today you can think of having SID variety and say this man may need insulin fast or an insulin secretagogue. Whereas an obese patient comes to you, you can say this looks like an IROD variety, the insulin resistant variety. Maybe this person will respond better to sulfonylurea or to an SGLT2 inhibitor. In the first group, SID, you may use a DPP4 inhibitor or secretagogue or insulin. Okay. Whereas the second group, you may treat them with the SGLT2 or a GLP1 receptor analog for that matter. And then if an older age group comes, MARD variety, okay, oh, this is a mild variety, we'll treat them with metformin. We won't, push them too hard because they're not going to develop complications. So that's how the field of type 2 diabetes is evolving. In the next 1 or 2 years, I'm sure lots more will come out of the precision medicine initiative that we're all working on. And finally, in monogenic forms of diabetes, precision diabetes has really come to stay. It is quite dramatic how in monogenic forms of diabetes, once you find the gene, you can completely change the treatment from an insulin to an oral drug, sulfonylurea, and the changes can be quite dramatic for that particular individual, for the family, and for the society as a whole. So we are very excited that we are passing through this time when precision diabetes is really come to stay. And thank you for the opportunity to share this at the annual conference of the Arabic Association Study of Diabetes Metabolism, AASD, and thanking once again Dr. Inas Shalhout, Dr. Shenas, Dr. Mohammed Hasneen, and all the others who are involved in the organization of this conference. Thank you very much.